Welcome, and I wish you all a worthy good day. At the outset, I thank the organizers of ISACON 2021 for inviting me to present a topic on the emerging mode of anesthesia, the total intravenous anesthesia, and I'll be talking about TIVA drugs and their combinations. The technique of administering general anesthesia with intravenous agents only and avoiding all inhalation anesthetics is called total intravenous anesthesia, or TIVA in short. The inhalation anesthetics are potent respiratory depressants and necessitate airway instrumentation and associated ventilation for maintenance. IV anesthetics directly enter the central compartment, bypassing the lung, and exerts its effects. There are useful IV agents like ketamine and dexmedetomidine, which maintain adequate spontaneous ventilation while providing surgical anesthesia. Understanding of TIVA will be inadequate without refreshing the pharmacokinetics. Intravenously injected anesthetic drugs first disperse in the plasma, the central compartment, or V1. From there, it rapidly equilibrates to well-perfused tissues like the muscles, or V2, and slowly to poorly perfused tissues like the fat, or V3. Elimination may be by metabolism or by excretion. Plasma concentration of any drug at any point of time depends on its bolus effect. Elimination and transfer, remembered easily by BET or BET. Effect site of an anesthesia is brain, and it is a small subcompartment of V1. There is a lag in the equilibration or hysteresis of plasma concentration and effect site concentration. Bolus injection has a peaking effect and leads to an overshoot of plasma concentration, or CP, and accelerates the rise in CE. Contact sensitivity half time is the time in which the plasma concentration of drugs reduced by 50% after discontinuing an infusion. Short CSST in for a quick recovery from desirable and is desirable for TIVA. As the CSST and duration of action of propofol and remifentanil are short, the emergence from these agents are also faster. Agents used in TIVA. Propofol is the preferred intravenous hypnotic agent of choice. It is used in place of an inhalation agent. Midazolam may be co-administered for its hypnotic effects. Agents that need special mention here are opioid analgesics, remifentanil and fentanyl, ketamine, which is a cataleptic and a dissociative anesthetics, adjuvant sedative and analgesic dexmedetomidine, muscle relaxants, NSAIDs, paracetamol, magnesium, lignocaine are among the many IV agents co-administered in inhalation as well as intravenous anesthesia. Propofol is the most commonly used principal intravenous anesthetic agent suitable for the induction and maintenance of TIVA because of its favorable pharmacodynamic and kinetic effects. Rapid onset, short CSST, no active metabolites, antiemetic, not a malignant hyperthermia trigger, and the benefits are many more. The complex mechanism of action of propofol is not well understood. It acts on GABA A in the CNS. Onset of action of propofol is rapid in one arm brain circulation time of 15 to 30 seconds. It is quickly redistributed and has a short duration of action of 5 to 10 minutes. The primary elimination of propofol is hepatic. It also undergoes extrahepatic metabolism in the lung, kidneys, and brain. Propofol pharmacokinetics in neonates are characterized by an increased sensitivity to intravenous anesthetics, and anesthetic doses have to be decreased. Infants and children have a larger central compartment, volume of distribution, and increased metabolic clearance, leading to decreased sensitivity. They need a higher dose. Propofol use is associated with the fall in cerebral metabolic rate and blood flow. Cerebral autoregulation appears unaffected. Large doses of propofol cause respiratory depression, accompanied by decrease in protective airway reflexes. Propofol maintains hypoxic pulmonary vasoconstriction and acts and does not increase the pulmonary shunt as with inhalation agents. Manual infusion plans by Prys-Robert. Propofol 1 milligram per kg is administered for induction of anesthesia, followed by an infusion for infusion of 10 milligram per kilogram per hour for the next 10 minutes and 8 milligram for the next 10 minutes and 6 milligram thereafter. Propofol is better administered with the target control infusion pumps, the details of which are out of the scope of this presentation. Opioids. Fentanyl and remifentanil are the potent opioids which a fast onset of action and early emergence. It provides intense analgesia and reduces the requirement for propofol in TIVA. Opioids exert their action stimulating various opioid receptors mu, delta, and kappa. Nociceptin favored descending inhibition of pain. They act in the supraspinal, spinal, and peripheral levels. Fentanyl is a synthetic opioid with a clinical efficacy of 100 times of that of morphine, usually administered by intermittent IV boluses. It has a reputation for having a short duration of action, limited by redistribution within the body. Pharmacodynamics of fentanyl and remifentanil are similar. Fentanyl is extremely lipid-soluble. Rapid uptake by brain leads to rapid onset of action within 60 seconds, peaks effect in 2 to 5 minutes. Redistribution to V2 and V3 and metabolic clearance by rapid extensive metabolism by the liver to inactive metabolite norfentanyl leads to short duration of action, 30 to 60 minutes after a single bolus dose. Negligible effects on the CNS, ICP, and CBF is undisturbed. Muscle rigidity and seizure-like movements are seen in a few and can be avoided by a smaller induction dose. Only a very high dose may produce negative inotropic effect on the heart. Advantages of fentanyl are hemodynamic stability, easy titrability, blunting of responses, noxious stimuli, and permitting rapid recovery. Not useful as a sole agent. Doses are induction 0.25 to 1 milligram, 1 microgram per kilogram, and maintenance 0.1 to 0.2 microgram per kilogram per hour. Remifentanil is a piperidine derivative with the methyl ester side chain. Ester group hydrolyzed by blood and tissue non-specific esterases into inactive metabolites. Volume of distribution at steady state of remifentanil is very low, showing low store in the tissues, no accumulation with the repeated dosing or prolonged infusion. The context-sensitive half-time of remifentanil remained flat at around 8 minutes, whatever the duration of action, due to its rapid elimination by ester hydrolysis. But CSST of fentanyl rises steeply after 60 minutes due to the increased tissue sequestration. It is a potent mu-selective opioid activity. Remifentanil appears to be ideal agent for co-administration with propofol for TIVA, which is not marketed in India yet. Ketamine is a phencyclidine derivative used as a general anesthetic, licensed for use since 1968. It produces painless and amnesic cataleptic state, described otherwise as dissociative anesthesia. The main mode of action is recognized as NMDA receptor antagonism, but it is also interacts with the opioid, muscarinic, and monoaminergic receptors. It has also shown to inhibit voltage-gated sodium and potassium channels and reuptake of serotonin and dopamine. Inhibition of L-type calcium channels leads to negative cardiac inotropy and airway smooth muscle relaxation. Agonism at AMP receptors lead to rapid antidepressant effect. Ketamine is highly lipid-soluble and rapidly distributed to brain that ensure rapid onset of acute analgesic effect. It undergoes rapid metabolism and redistribution to peripheral tissues. Norketamine is the main metabolite and is 20 to 30% as potent as the parent compound. Ketamine has direct negative inotropic effect on the heart and a predominant indirect stimulatory effect secondary to sympathetic system activation. Ketamine produces airway relaxation and has minimal effects on the central respiratory drive. As ketamine increases cerebral metabolism, it can potentially increase the intracranial pressures. However, when used in combination with the propofol or midazolam, ketamine cerebral effects may be neuroprotective and potentially beneficial even for traumatic brain injury. The predominant and disturbing side effects of ketamine are psychoactive. This made ketamine unpopular anesthetic in the last century. Dexmedetomidine, introduced in 1999, was a game changer which can effectively counter most of the side effects of ketamine, psychoactive, sympathetic, and cholinergic. Midazolam and propofol are also very useful for this purpose. This has led to the reintroduction of ketamine back to the mainstream anesthesia. Ketamine remains the predominant and primary anesthetic for short procedures done under spontaneous breathing. Uses of ketamine, advantageous settings for anesthesia are induction of patients with hemodynamic instability, pediatric patients, uncooperative patients, traumatic brain injury, bronchospasm, outside operating room anesthesia. Ketamine, analgesia and sedation. Procedural sedation and analgesia, labor pain, burns, emergency medicine, agitation and pain, post-operative pain, emergence phenomenon, post-operative shivering, all this can be controlled with ketamine. Dexmedetomidine is a new generation highly selective alpha-2 agonist with a selective sedative and analgesic effect, approved in 1999 by the US FDA as a short-term sedative and analgesic for intensive care units. The drug has an anesthetic sparing effect and can be used as an adjuvant to general anesthesia, total intravenous or inhalational. Maintenance of muscle tone, lack of respiratory depression, and analgesia is the hallmark of this agent and helps to maintain spontaneous breathing under TIVA. It exerts blunting of pressure response and hyperalgesia during intubation and extubation. It prevents post-operative shivering and emergence agitation, facilitates early and awake extubation. The onset of action of dexmedetomidine is slower at 5 to 10 minutes. Peak effect is reached 15 to 20 minutes, so it is better administered in advance. Duration of action is less than an hour due to this fast redistribution. Tend to accumulate, and the CSF rises to 250 minutes after 8 hours of infusion. Can be used as a sole anesthetic agent. Dose is 1 microgram per kilogram for induction and followed by 0.2 to 0.7 microgram per kilogram per hour for maintenance. The most frequent adverse effects include hypotension, bradycardia caused by rapid bolus administration. It should be used with caution in patients with bradycardia and atrioventricular blocks and can be managed with adrenergic agents. TIVA combinations. Various combinations of anesthetic agents are becoming increasingly popular. It aims in the addition of favorable anesthetic properties and control of untoward effects. Due to synergy, lower dose of individual drug only is needed. Ketamine and ketodex are examples. Various fixed combinations are used in different hospitals. It can be used in infusion or by intermittent boluses. Ketofol. Ketamine and propofol are mixed in the same syringe in varying ratios from 1:2 to 1:6. Higher ketamine ratios, 1:2, is usually useful during the induction and lower ratios for the maintenance. As ketamine tend to work for longer, it tend to accumulate. Hallucinogenic effects of ketamine is dampened by propofol. Dose of propofol is low and do not produce respiratory depression or airway collapse. Ketodex. Ketamine and dexmedetomidine are good analgesic, and this effect is additive, decreasing the dose of each. Both do not cause respiratory depression or airway collapse in the useful doses. Dexmedetomidine produces sedation similar to natural sleep and antagonizes the hallucinations produced by ketamine. Ketamine increases secretions and dexmedetomidine is a drying agent. Ketamine increases BP and heart rate. Dexmedetomidine do the opposite. Thus, these two make a wonderful combination. One of the most prevalent ratios is 2 milligram of ketamine to 1 microgram of dexmedetomidine. Ketodexafol or KPD mix. Adding propofol to ketodex helps to reduce the requirements of both ketamine and dexmedetomidine and promote faster onset and early emergence. 100 microgram of dexmedetomidine, 200 milligram of ketamine made up to 20 ml with propofol is a usual premix. Premixed fixed combinations are useful in short procedures only. During long procedures, long-acting drugs tend to accumulate and the requirement falls. Whereas propofol requirement is the same as it is disposed faster. Using various drugs individually according to the physical status and requirement of the patient and surgical scenario has its own advantage. It allows more versatility. Example, in a hypertensive patient, dexmedetomidine may be administered in advance to establish control of BP and heart rate well before ketamine, the doses of which may be reduced. I personally don't favor the fixed combinations and I always use it from separate syringes according to the clinical evaluation. So TIVA has many advantages. TIVA with spontaneous breathing can avoid air instrumentation and assisted ventilation for short procedures. TIVA is feasible and probably a preferred option for prolonged anesthesia with muscle relaxation and IPPV also. Thanks a lot for patient hearing.